Our next speaker is Associate Professor Homaira, a medically trained paediatric respiratory epidemiologist with almost 2 decades of working experience in prevention and control of respiratory infections of childhood, particularly in low, middle and high income settings. And the topic of her talk today, whooping cough, strategies employed to address outbreaks and minimise future epidemics. Thank you.
Good morning, everyone. I want to begin by acknowledging the traditional custodian of the land and of the ones where I work and I live. And I also want to pay my respect to any Aboriginal and or Torres Strait Islander here present, elders past and present. So my talk is today around whooping cough. I'm mainly going to talk about the strategies to sort of prevent and control outbreaks. And these are my conflict of interest. So pertussis or whooping cough, it's more popularly known as whooping cough. It remains a global public health problem in both high and low middle income countries, and in most settings it remains as an endemic disease. But every 3 to 4 years we do see peaks in cases. There's epidemics even in high income settings. And this epidemics that we see every 3 to 4 years is mainly driven by waning immunity in the sort of adolescents and older population. So that's problematic for whooping cough. The disease was first described in a Paris epidemic in 1578. It's caused by Bordetella pertussis. And it's also, as I said, more popularly known as whooping cough. It was also called as the 100-day cough because of the prolonged coughing episode that we see with this disease. And adults and children, particularly protected by the vaccine, can present with mild illness, not with the classical disease. And they are also the population where we see a waning immunity and hence the risk of transmission of the disease and then leading to epidemics. So looking into the timelines of the disease, there are 3 classical stages of the illness. So first is the cataract stage, which can mimic like a common respiratory infection, with mild symptoms like a runny nose, sneezing, slight cough. Sometimes there can be low-grade fever. But this phase is generally around 1 to 2 weeks. But this is the most infectious phase. This is the time where we see the majority of the transmission as well. And as that sort of cataract stage decreases, the infectiousness also comes down. Then comes the paroxysmal stage, which is the classical stage where we see the prolonged coughing and the coughing with the whoop sound, and also the post-tussive emesis, so vomiting after coughing. And then comes the convalescent stage, which is marked by less frequent and less severe coughing episodes. And the last 2 stages are not as infectious as the first one. That's when majority of the transmission will happen during an epidemic. So children often present with the classical symptom, which is the paroxysmal cough, frequent coughing, and also the whoop sound, followed by antitussive vomiting. But younger children, infants often do not present with these classical symptoms. With infants, we see more as a classical symptom is apnea, holding their breath, which we also see with severe RSV disease. So that often is the main symptom that infants present with. They can also have exhaustion, lethargy, all those classical symptoms that are not common to any particular pathogen, but may be present in most severe respiratory infections in infancy. So the mode of transmission, humans are the only known reservoir for the disease. Again, like I mentioned in the beginning, adolescents and adults remain a source of transmission because of the waning immunity. There's fortunately no sort of chronic carrier state, so there's no ongoing transmission. And mostly it is through large droplet transmission, or fomites can also get contaminated. So what happens is when somebody has the infection, when they cough or sneeze, the droplet falls on somebody else, and that's how you get exposed. But there are some evidence that suggests that longer distance transmission can also happen within more than a meter with pertussis. So mainly it's through direct contact with respiratory droplets. The incubation period can range between 4 to 21 days, but usually it's 7 to 10 days. And like I said in the earlier slide, that the catarrhal stage is when a person is most infectious. That's when the transmission also happens, and that's also when an unimmunized or incompletely immunized person, when he's exposed, will pick up the infection. And it's so infectious, that stage, that almost 90% of our household contact, if they're unimmunized, can pick up the infection. But a case is considered to be non-infectious, even if the PCR result is positive, because we all know that PCR results can continue to be positive for a longer periods, because PCR picks up remnants of a pathogen. So even if the PCR result is positive, a person is considered non-infectious after 21 days of the onset of the cough, or 14 days after the onset of the paroxysmal stage, where they have the vigorous cough, or after completion of 5 days of appropriate antibiotic. That's when a person is considered non-infectious. I think these definitions are important, particularly when we are having an outbreak or an epidemic within a setting. So like Rama mentioned, for pneumococcal disease, I think vaccine, we would all agree, vaccine remains the key public health intervention to prevent any sort of infectious disease. And pertussis is one of the most common vaccine preventable infections that we see. And again, like most other vaccine, the vaccine is designed to prevent severe disease. And there are two types of vaccine. One is the whole cell vaccine, which has the dead pathogen, and the acellular vaccine, where there is one or several modified antigen in the vaccine. So here I have the sort of immunization schedule for Australian context from the Australian Immunization Handbook. Different settings have different guidelines, although in general the concept is same across most settings. The difference remains in the boosting. When do we get the boosting? So, and the ones that are highlighted in red in this sort of immunization recommendation are the ones that are covered within the National Immunization Program. So we have a National Immunization Program that protects infants with a routine booster dose, with the acellular vaccine for adolescents at age between 11 and 13 years, like a school-based vaccine program. And then we also have vaccination for women during pregnancy, which is covered under the National Immunization Program. But then it's also recommended for other adults who are at high risk of being exposed. So, healthcare workers, early childhood educators, people in close contact with infants, they are all recommended for the vaccine. However, it's not covered within the National Immunization Program. So again, that raises the issue around equity and access. And there is a special program within the National Immunization Program for refugees and people coming in on humanitarian grounds into Australia, so that there's a catch-up program if they're not completely vaccinated to prevent the transmission or risk of transmission. So that's the prevention of the disease, the routine prevention. And another key important thing for any infectious disease prevention, not just pertussis, is routine surveillance. Thankfully, in our country, we have the National Notifiable Disease Surveillance System, and this is a notifiable disease, so all known cases of pertussis are recorded. But in many parts of the world, the data are not very complete. There is not an ongoing surveillance system in many countries, which makes which can be complicated in outbreak settings if you don't have a good surveillance system. So I think that routine surveillance system also plays a huge role in prevention of any infectious disease. So in the beginning, I mentioned that even though it's an endemic disease, every 3 to 4 years we do see epidemics, or we see increase in cases, and that's what happened in 2023 as well. This is the data from New South Wales. There was a huge peak in cases. What also happened in 2023 was the coverage of the third dose of the vaccine in children 12 months of age was 93%, which was 0.6% lower than in 2022, and remaining below the national target, which is 95%. And the same thing happened for the adolescent vaccine as well. There was a dip in the vaccine coverage. And we all know post-COVID, we have been seeing that slight changes in the uptake of the vaccine. Again, for these type of infectious disease where we do have good vaccines, which we know are very important in preventing these infections, maintaining a high uptake rate is crucial so that we don't see all these epidemics and these outbreaks. So in terms of control of whooping cough, when we have an epidemic or an outbreak, it's a notifiable condition in Australia, which means we get notified. And like any other outbreaks of infectious disease, there are usually 3 stages to the control of whooping cough outbreak. One is first we do case and contact management, and then we have an outbreak response. How do we handle the outbreak? And third, of course, the education and engagement with community members and healthcare workers and all that. These 3 are essentially the key steps in any outbreak management and also for whooping cough. So for case management, antibiotics, if they're started early, it seems that it can reduce transmission by reducing the load of the pathogen. And also, because it's a very infectious disease, it's very important to be able to isolate the case and inform family members of the infectiousness and the risk of transmission from the case. So if there are high-risk individuals within a household or within a childcare setting, they should try to avoid contact with those cases. And in terms of contact management, close contacts are, there can be close contacts who are, family members, who work in the same setting very closely, but there are also high-risk contacts who are not necessarily family members or may not have been working in the same place, but they have underlying condition that puts them at higher risk. So there are 2 different types of contacts, and in such settings, it's important to understand how many these type of contacts have come into places. Again, contact tracing is key. So we find out how many people have come in contact with the case, but when there is a widespread outbreak of pertussis or whooping cough, it might not be very resource feasible to sort of trace every contact. So rather we often go with the concept of close contacts or high-risk contacts. So that's a sort of a strategy for controlling whooping cough outbreak, because it's not logistically always feasible to sort of contact everyone. So, and then there is also the guideline for post-exposure prophylactic treatment for contacts. Again, antibiotics, if given before the onset of symptom, can reduce the disease. However, in large settings, it is not recommended that all contacts receive the antibiotics. Again, there are guidelines. So if there is a household contact, if there's within a household there is an incompletely vaccinated child who's less than 6 months old and somebody in that household gets the disease, then it's recommended that all household members receive post-exposure prophylactic antibiotic treatment. But for other households, there is no recommendation. It's only if there is an unimmunized infant in the household who's less than 6 months of age. Again, similarly for childcare setting, if there's an incompletely vaccinated child who's less than 6 months of age, then all children and all sort of staff within that childcare should receive the antibiotics. But with childcare where there is sporadic cases and where all children are more than 6 months of age, there's no need for antibiotics for everyone. Similarly, there are different guidelines for the use of antibiotics. Again, I'm not going to read out all of them, but there are specific guidelines. Again, it is sort of guided by the decision that we give antibiotics to close contacts, people who are in close settings like childcare, like hospitals or family, and where there are high-risk individuals like pregnant women or children who are less than 6 months of age. In those type of settings, the goal is to give antibiotics to everyone post-exposure. But other than that, in most other settings, antibiotics, the data doesn't suggest that antibiotics are really very helpful. So outbreak response, like I said, that the first thing is when you find out a case, you try to find out if there are other cases. And again, there is a definition to identify case. And when do we call it an outbreak? Because it's a very infectious disease. Pertussis is a very infectious disease. If there is 2 or more cases share a possible epidemiological link, which means that they were in the same place at the same time and sort of, they're related with person, place, and time, and there are more than two or more cases, then we would potentially say that there is an outbreak going on and there is an epidemiological link between them. And an outbreak, a case definition of cough illness lasting for more than 14 days may be used. It's not necessarily to have all cases confirmed by lab diagnosis when there is an outbreak going on. If there is an epidemiological link and if they share similar symptoms and there is a history of prolonged cough, then they can be considered as a suspected case for pertussis. And because it's a very infectious disease and it's very important that we are able to identify close contacts, we're able to isolate cases and manage those cases, investigation should ideally start within 2 days of being notified of a potential outbreak. And each suspected case should result in contact tracing. Again, we can't do massive contact tracing, mostly household contacts and close contacts or high-risk contacts. That's what we are trying to aim for in such settings. And again, as part of outbreak response, there's something also that happens simultaneously during outbreak investigation is we also plan for other things. So while we are doing the outbreak response, we also want to know, is there a particular risk factors that's led to this epidemic, or is there a particular reason why this epidemic is happening? So we do other studies simultaneously to understand the sort of the mode of the transmission of the outbreak. And also media alerts to the healthcare providers, the people who are involved in frontline to raise awareness. There is a cocooning vaccination strategy that's often used in pertussis. It's mainly, even though vaccination post-exposure doesn't prevent the disease, but oftentimes with pertussis what happens is if there is an infant in the household, you want to update all adult members within the household with the vaccine so that the risk of transmission reduces. This is a strategy that's often used in whooping cough. The other important is making sure that everybody is up to date with their vaccination schedules and everything. So those are sort of some of the outbreak response. Again, vaccination is not a strategy to control an outbreak, but because it's an infectious disease, when we have an outbreak, that is also sort of a reminder for us as healthcare providers to check whether vaccination schedules are up to date or not, whether we have the high-risk people vaccinated or not. So if there is a case among children in childcare settings play a huge role in outbreaks. There are often, we see outbreaks being reported from childcare, again, because it's a closed setting. There are many children within that setting, and like any other respiratory infection where there are multiple children in a closed setting, there is a risk of transmission if all children are not immunized or incompletely immunized. So again, if there is an outbreak in childcare setting, while we are doing case management and contact tracing and the other things, it's also very important, and it should be one of the key strategies to update on the immunization status of all the children within the childcare setting if they have up-to-date immunization. Same thing for family daycares. They may need to be closed down temporarily if there are multiple cases. I've come to the end of the slide. I realize I'm running out of time. For control of spread within household, it is a respiratory pathogen, and like any respiratory infection, and we have heard this multiple times during COVID, it's the same for any respiratory infection. We have to protect our sneeze, our cough, coughing on elbows, using tissues, disposing the tissue immediately in a waste bin. If your child is sick, try not to send them to childcare setting. If you are unwell, try to work from home or not go to work. So these are essentially the same steps for any respiratory infection. So again, that can help control the spread of the infection within the household. Health education, providing education to community, to doctors, to healthcare providers, everybody who's involved in that sort of care pathway during an outbreak. Yes, with that, I've come to the end of the presentation. Thank you.
Excellent. Thanks so much for a great presentation. I'll just remind everyone there's a panel discussion coming up, so we might hold questions from the room for that. I do have one quick question online. So 2024, highest infection rate since records began, 10 to 14 years with the highest group infected, and the spreaders, Year 7 schools program, but unsure of uptake there. Should this group be the target to focus on for vaccination?
Exactly. I think those are the groups that we should target for vaccination, and there are vaccination schedules for them. Again, the uptake has gone down in that group, and we have to sort of be persistent in our efforts to keep the vaccination coverage, the uptake more consistent. But I also think in general we are suffering from a vaccine fatigue, which is problematic in public health because for public health interventions, vaccines remain the most important intervention.
Right. Thank you. Yeah, thanks very much for a fantastic talk. I think the role of additional boosters and who to target might be something we can come back to in the panel discussion. Yeah, please join with me in thanking Associate Professor Nusrat Homaira again.